Welcome, future doctors. Let's get right into today's rapid review ward walk. I'm going to be your attending for this session. And look, today we're tackling the absolute heavy hitters of pulmonary medicine. We're going to take all those dense, dry textbook pages and turn them into crystal clear patterns that you're going to recognize instantly on the wards, and of course, on test day. Okay, let's dive into this explainer and get you prepped to absolutely crush your exams. Here's our rounding list for today. We've got the respiratory foundation, lung volumes and capacities, obstructive versus restrictive patterns, mastering flow volume loops, and finally, high-yield clinical scenarios. Just keep this little roadmap in the back of your mind as we conquer these topics.
All right, let's kick things off with Section 1, the respiratory foundation.
Before we can figure out how the lung breaks, we absolutely have to understand how it's built, right? Notice how perfectly this architecture maps out the transition from the conducting zone all the way down into the respiratory zone. Up in the trachea and bronchi, you've got this sturdy cartilage and these thick, robust layers of cells. But as we move down the bronchioles and finally hit those respiratory bronchioles and alveolar sacs, well, the structural support just thins right out. And it has to, so we can allow for that super delicate gas exchange.
Okay, time for a quick pimp question. Which of the cells listed here actually produces surfactant? If you said type 2 cuboidal pneumocytes, you are absolutely spot on. Listen, these histological features are straight up USMLE gold. Remember, the upper airways really rely on those pseudostratified ciliated columnar cells to just sweep away debris. Meanwhile, those type 2 pneumocytes down in the alveoli, they're busy secreting dipalmitoylphosphatidylcholine. Yeah, that's surfactant, which drastically decreases surface tension so your lungs don't just collapse on themselves. You have got to know these histology hits cold.
Moving right along, let's hit Section 2, lung volumes and capacities.
So, we've built the lung, now let's actually look at how the lung breathes. Imagine your patient is just breathing normally, nicely relaxed. See that little wave right in the middle? That's your tidal volume, typically hovering right around 500 milliliters. Now, if I ask them to take the absolute deepest breath possible, boom, we add the inspiratory reserve volume. And if they exhale as much as humanly possible, that's the expiratory reserve volume. Notice how these individual volumes literally just stack right on top of each other to create your broader lung capacities? It's like building blocks.
Now, the crucial point here is this specific capacity, functional residual capacity, or FRC. Why do we care so much about FRC? Well, because it's the neutral baseline equilibrium state of the whole respiratory system. It's exactly that sweet spot where the inward elastic recoil of the lungs perfectly balances out the outward spring-like recoil of the chest wall right after a normal, quiet breath.
And on the flip side of that, we have total lung capacity, or TLC. This is literally the absolute maximum volume of air the lung system can hold after a maximal inspiration. Understanding this ceiling, this maximum boundary, is absolutely essential. Why? Because as we're about to see, different pathologies are going to either stretch this boundary way out or shrink it right down.
Which brings us right to Section 3, obstructive versus restrictive patterns.
All right, this is the big showdown. This is where we learn exactly how the lung breaks. And let me tell you, it is heavily tested. So let's simplify this. I want you to picture obstructive lung disease, think asthma or emphysema, as trying to blow air out of a tiny collapsed straw. There's just massive airway resistance, and you simply cannot get the air out, which naturally leads to air trapping. On the other hand, restrictive lung disease, like pulmonary fibrosis, that's like trying to inflate a thick, incredibly stiff rubber balloon. The lungs lose their compliance, they become super stiff, and their elastic recoil just shoots right up.
And this brilliantly illustrates exactly what those analogies mean for our actual lung volumes. Check out that pink section representing residual volume. In the obstructive column on the left, that collapsed straw traps so much air that the residual volume just balloons up, totally expanding the total lung capacity. But then, look over on the right at the restrictive pattern. That stiff rubber balloon just squashes everything down. Every single volume and capacity shrinks.
Let's keep this momentum going right into Section 4, mastering flow volume loops. Now, whatever you do, don't let these intimidate you. Yes, they are some of the most heavily tested visual charts in the USMLE, but I promise they're actually incredibly simple to grasp. Pay really close attention to the shape of the expiratory curve. That's the top half of the loop. On the left, looking at the obstructive pattern, do you see that characteristic scooped out or scalloped shape during expiration? That right there is your tiny collapsed straw severely limiting airflow as the patient exhales.
Now glance at the restrictive pattern on the right. The shape is, well, relatively normal, but it looks like a miniature version. The entire curve is super narrow and shifted far over to the right, toward the lower lung volumes. It perfectly reflects that stiff, hard-to-inflate balloon.
Let's move on and see how this builds when we put them all together. Seeing all three of these curves beautifully overlaid really anchors the pathophysiology directly to the visual shifts. The normal green curve? That's your baseline. The purple obstructive loop shifts left, showing those massive volumes and that scooped top. And the orange restrictive loop? It just shrinks down and shifts right. Seriously, burn this image into your brain, doctors. It will absolutely earn you free points on test day.
Take a deep breath. We are now entering Section 5, High-Yield Clinical Scenarios.
Welcome to the final rapid-fire phase of our ward walk. This is where we test that new pattern recognition of yours. Here's your first scenario. A 72-year-old female is participating in a longitudinal study comparing her lung function to a 20-year-old's. I want you to think about the natural physiological changes of the aging lung. What specific parameters are going to go up and what's going to go down?
Time's up. So, as we age, our chest wall compliance steadily decreases. Our ribs and joints just get stiffer over time. At the exact same time, we've had a lifetime of inhaling particulates, which leads to changes that actually mimic obstructive lung disease. Because of this combo, her residual volume is going to go up due to air trapping, her arterial PO2 goes down, and her AA gradient noticeably widens.
Okay, next case. We have a 38-year-old heavy smoker. If we were to take a look at her airway tissue under a microscope and compare it to a healthy non-smoker, what precise cellular and functional changes are we going to see? Think back to the defense mechanisms of the respiratory tract we talked about earlier.
Well, the smoke acts as a massive constant irritant, so you're definitely going to see increased mucus production as those glands hypertrophy. But the real high-yield, totally insidious step 1 fact here? It's that the pseudostratified columnar epithelial cells actually lose their ciliary function. They literally stop sweeping away debris. You combine that with a drop in alveolar macrophage function, and you've got the absolute perfect setup for chronic bronchitis and recurring infections.
All right, final pimping question of the day. Let's pull it all together. You've got a patient whose spirometry shows a low forced vital capacity and a low functional residual capacity. You order a chest X-ray, and the radiologist notes a classic reticulonodular pattern. Based on the physiology we just covered and that imaging finding, what is your diagnosis, doctor?
It's restrictive lung disease. You have a global decrease in lung volumes, which is screaming our stiff balloon physiology. And that chest X-ray buzzword, never ever forget it. When you see reticular or reticulonodular opacities, the exam is literally shouting restrictive interstitial lung disease at you, something like pulmonary fibrosis. Match that stiff pathology to its visual X-ray counterpart, and honestly, you can't go wrong.
And just like that, rounds are complete. You've mastered the anatomy, the volumes, the loops, and those classic clinical scenarios. At the end of the day, medicine is really simply about understanding the normal baseline and recognizing the patterns when that baseline shifts. But before I let you go, ask yourself this. What happens when a patient presents with a mixed obstructive and restrictive picture at the exact same time? How do those flow volume loops change then? Well, we'll leave that little mystery for your next shift. Trust your patterns, trust your physiology, and go ace that exam.